Okay, so hopefully we are back to recording here. I don't usually pause in the middle of anything, but I had to take that call real quick. Okay, so let me reshare my page here. All right, and now we are on platelets. All right, platelets. I'm going to go back to this page because it appears that maybe I was muted. So I'm going just to repeat what I just said here. Is that the platelets, also known as thrombocytes, are an anucleate fragment of a larger cell called the megakaryocyte and are essential for clotting process. They adhere together to form a platelet plug, and then they produce an enzyme called prothrombinase. So over to the right here in this image, those little purple spots, like you took a purple magic marker and just and hit the background there. Those are the thrombocytes. Right, platelet production. Thrombopoietin is the hormone produced in the liver that regulates platelet production and triggers the formation of megakaryocytes. And each megakaryocyte can produce about 2 to 3,000 platelets in bone marrow. That's a lot. Platelets then enter the bloodstream. So this is a picture of a megakaryocyte. It's this huge cell. That's why they call it mega. And that the platelets are kind of exfoliating into little fragments right off the surface. Hemostasis includes these 5 stages. We start with a vascular spasm. Blood vessels constrict to slow down blood loss. So picture this: if you cut a vessel, you're losing blood. Well, if you're hemorrhaging and you're losing blood, then you don't want to encourage more blood to go there and be lost from the cardiovascular system. So it kind of makes sense that you're going to have a vascular spasm. That's followed by that platelet plug that we just referred to. Platelets stick together to form a plug. Then it's followed by coagulation, which is clot formation. Then the clot retracts and repairs. So where you have 2 areas of a blood vessel that essentially has a crevice or an opening between it, the clot starts to pull the sides of that blood vessel back toward one another, so that the endothelium, the smooth muscle layer, and the outer connective tissue layer, that blood vessel, can all kind of refuse again, and uh, uh, allow that opening to now be closed, essentially. But it draws the edges of the blood vessels together and then kind of mends them back together again. And then that's followed by fibrinolysis, where we use fibrin, or plasmin, I should say, as an enzyme that helps break down some of the clot now that we don't need it there anymore, and that, now it is hopefully repaired back to almost a normal looking blood vessel. Blood coagulation. So blood coagulation is triggered by cellular damage, or blood contact with a foreign substance, and a blood clot forms. So there are 2 different sort of pathways and etiologies, for blood coagulation. It's a hemostatic mechanism and causes the formation of a blood clot via a series of reactions, which activates the next in a cascade of reactions. And it occurs either extrinsically or intrinsically. So I like this picture because it helps you see the difference between both pathways, the different steps involved. But then in the middle, they follow what's called the common pathway. So even though, let's say over in the green side here, the extrinsic pathway, that begins with endothelial injury, which means the blood vessel is actually injured somehow, and it secretes what's called tissue factor. And that tissue factor, is going to convert factor 7 to 7A. So when you're looking at these factors, and not that I'm going to ask you really about these factors, but when we have A in that, it means it's the activated form of, let's say, factor 7. So we have factor 7. Now that it's activated, we call it factor 7A. All right. So it takes only a few steps in the extrinsic pathway before it enters into the middle here in the gray area as the common pathway, converting factor 10 to 10A and so forth and so on until we finally have fibrin down at the bottom. Right? The intrinsic pathway over to the left-hand side, all in gray, goes through a few more steps and factor conversion before it enters into the common pathway. But what stimulates the extrinsic versus the intrinsic pathways are different, and they have different anticoagulants associated with them. Right, so the extrinsic clotting mechanism is triggered when blood essentially comes in contact with a damaged blood vessel wall or tissue, such as a laceration. Right? So you have some kind of the endothelium is the inner layer of a blood vessel, and somehow that has become injured somehow. Yeah, and so an easy way to think of it is, let's say you just cut yourself and you had a paper cut and you start to bleed a little bit. Okay. Chemicals outside the blood vessel trigger the blood coagulation. And Coumadin is the anticoagulant in this pathway. Okay, the intrinsic clotting mechanism is really a different type of stimulus for clotting. It can be triggered when blood contacts a surface or exposed collagen, unusual surfaces. When it's kind of hard to explain, but when, let's say you had a valve replacement in the heart, that forever, even though it depends on what the replacement is, and what is made of, is that it's generally going to be considered by your body something foreign. And as blood fat passes over structures like that is foreign, it goes through areas of a lot of turbulence. When it comes in contact with, let's say, as you do a blood draw, let's say you're trying to do venipuncture and you're getting a specimen of blood, as the blood passes through the needle and vacutainer, that it's being stored in, it's coming across an unusual surface that can trigger this intrinsic pathway of clotting. So chemicals inside the blood vessel trigger the blood coagulation, and heparin is the anticoagulant in this pathway. Right, the common pathway is going to be used toward the end by both intrinsic and extrinsic pathways. A stable clot is formed at the end, and plasmin digests that clot when it's no longer necessary. Okay, factors affecting clot formation. Well, inadequate vitamin K. K is necessary to form clotting factors in proteins produced in the liver. The anticoagulants that inhibit clot formation. Heparin, produced by basophils and mast cells, inhibit thrombin. Coumadin, or otherwise known as warfarin, is an antagonist to vitamin K. And aspirin is an anticoagulant, inhibits platelet clumping. I believe in here, and if the notes are slightly different when you actually see this, and you're listening to, if you do listen to my Zooms, I might come back in here and just put an extra little, in parentheses, because I thought I did this already, was that I just wanted to reinforce here that heparin, would be the anticoagulant in the intrinsic pathway, and Coumadin is the extrinsic pathway. I just want to reinforce that because for you guys going into nursing, they're going to be asking you that from about the first semester onward. So if you see that the notes have slightly changed a little bit, you know why. I try not to do that very frequently. And remember also the aspirin is an anticoagulant, and it's actually a pretty good one. A thrombus is an abnormal blood clot, and an embolism is a blood clot moving through that's now free floating and moving through the cardiovascular system and the blood vessels. Something to keep in mind that, aspirin, it actually is a pretty potent, I should say, or effective anticoagulant. if you're getting any kind of, and anyone that is, especially kind of takes aspirin on a regular basis, um, if they're going to have any kind of oral surgery or any kind of surgery whatsoever, even rather minor surgery, you need to stop taking aspirin for a good 5 days or so. It actually stays in the system a lot longer than you think, even though maybe the analgesic component of it you're no longer experiencing. That is actually residually in your bloodstream. So you need to go off that for a good 5 days before you have any kind of minor surgery or major surgery, of course. All right, blood groups and transfusions, antigens and antibodies. So these are about the last 10 slides. We're going to talk about blood typing, and how you determine what a blood type is and what is it to be blood type A or blood type B. Well, it requires that we kind of be familiar with these terms, and agglutination is the clumping of red blood cells in a response to a reaction between an antibody and an antigen. Right? So agglutination is this clumping reaction. It looks like a mass of, it's going to be a mass of cells and the antibodies that are attaching to these antigens that are on the cell surface. So the antigen, we'll come back to that. An antigen is a chemical found on the cell surface. They stimulate cells to produce antibodies. And an antibody is a protein that can attach to a specific antigen. So these antigens are like those major histocompatibility complexes that I referred to before. It's this chemical or stamp of molecules that's on a cell surface, and that's called an antigen. When we look at our blood types, we can anticipate certain antigens that are going to be found on the cell surface. There are about 300 different antigens that are capable of being on a cell surface, but when we ABO positive, negative, RH type blood, we're looking at these specific ones and the antibodies I would expect to find in their plasma. Okay, so based on the presence or absence of two major antigens on the red blood cell membranes is how we determine what the blood type is. And we have A antigens and B antigens. So we're not talking about RH right now. We're just going to look at A and B antigens. Right, so when you have A antigens on your red blood cell surface, we call that being blood type A. And when we have A antigens on our cell surface, we will automatically make, by about 6 months of life, B antibodies. If you have B antigens on your cell surface, then we call you being blood type B. And you make A antibodies automatically. Now, if we have both A antigens and B antigens on the cell surface, that's called being blood type AB. And that person will make neither A nor B antibodies. And when you're blood type O, it means you have neither A nor B antigen on your cell surface. I call it being a bold red blood cell. And that person will make both anti-A and anti-B antibodies. So it's important that you understand that you don't normally make antibodies to antigens that are on your cell surface. Right? I have a couple of videos that are up on the course page, and one of them is this really pretty older dude. I think he's even older than I am. But the other one is this kind of a younger dude, and that's a good one to actually download and keep maybe on a flash drive for when you get into the nursing program, because toward the end of it is really how you're going to use it in some of, I believe it's like in semester 2 of nursing. You get back into a lot of this blood typing and whatnot, and what bloods can be transfused and so forth. But it gives you a pretty good visual for that, and that's why I like it. So it's really quite useful. Right. So as I was saying, is that unless you have an autoimmune disorder, you don't normally make antibodies to your antigens. So here in blood type A, the reason why I'm saying that is that, see, when you have A antigens on your cell surface, you're not going to make A antibodies. Because if you made A antibodies are designed to bind to A antigens and only A antigens. And B antibodies are designed and shaped to bind to a B antigen. Right? They are going to be lock and key specific. So if you have A antigens on your cell surface, you certainly don't want to produce A antibodies. you will make B antibodies. And if you're blood type B, you make anti-A's. If you have A and B antigens on your cell surface, then you don't want to make either B or A antibodies because they would bind to the A and B antigens and you'd essentially kill yourself. And because you lack both of those A and B antigens on a blood type O, you make both of those A and B antibodies because there's no risk of those antibodies binding to your own cells. Right? So here you see this relationship. So on the top we have, blood type AB, where the A's are those purple triangles and the B's are those green balls. Right? So those are going to be the shapes, of those antigens. So let's look at blood type B. You have the green balls all the cell surface because you have B antigens. And look at your A antibodies. There's no way that antibody can bind, lock, and key to that B antigen. But take that A antibody and put it up here, up on top in the AB blood, it could bind to the A antigen. Down below in blood type A, you make B antibodies. Now you can see how that B antibody could bind to a B antigen. That's why blood type B people don't make anti-B antibodies. And then in the bottom, blood type O, here you have a bald red blood cell. You have neither A nor B antigen, and you make both of those antibodies. There's no risk of them binding to your own cells. Okay, let's just kind of quickly look at the blood that can be received, or be transfused to a blood type AB, B, A, or O person. I think it's good to kind of keep that in mind. Blood that can be received is blood type A, B, AB, and O. And it's called, so when you're AB, you're called a universal recipient. Why? Because you make neither A nor B antibodies. So any of those cells could be transfused into that patient. Now, remember let's just mention that because you might not know this, is when you transfuse blood, you transfuse the packed cell. You don't transfuse whole blood, right? Whole blood, the only time you generally transfuse any whole blood is when you have a self donor, where I know I'm going to have, let's say, knee surgery. So I donate blood ahead of time in case I need a transfusion during surgery in, a month or two. And you freeze that blood for the patient. And believe it or not, that costs more to have your own blood frozen and then made available to you than it does if you had a donor from someone you never met. I think it's kind of unusual. But anyway, so that's one of the only times. And there are a few other times, but if you're going to stockpile some of your own blood, that you might need a transfusion, during a surgical event that's being planned. But what usually is going to be transfused is when you have a donor blood, you separate the red blood cells and you put it in essentially saline, and you take everything else that was in plasma, the antibodies, all the other white blood cells and so forth, go someplace else because they can be used for other purposes. So the only thing in this bag of blood that you're going to transfuse is the red blood cells of a donor in just saline, just in fluid. Right. So you don't have to worry about what antibodies that A and B and people make. You don't have to worry about that. You just have to worry about is what is on the cell surface. What are the antigens on the cell surface of the donor's blood? Will that interact with any antibodies that the recipient or the patient has? All right, so if you're blood type O, you can receive from B and O. If you're blood type A and O. And blood type O can only receive from O. So they are the universal donor, but they're not a universal recipient. They can only receive blood type O because they're making A and B antibodies. So it couldn't receive an A because the A antibodies will bind to the antigens on a red blood cell A, and the same for a blood type B or an AB. So O's can only receive from O's. All right, Rh blood group. The Rh blood group is named for the rhesus monkey. Rh positive means you have this Rh antigen on your cell surface. And when you're Rh negative, it means you don't have it. Now, when it comes to these antigens, you don't automatically make antibodies to an Rh antigen if you're Rh negative. You have to be exposed to blood. right? You have to be exposed to a red blood cell that has the Rh antigen on the cell surface. Kind of like when we make getting a vaccine, to a virus, is that you don't normally, just because a virus is out in the environment someplace, doesn't mean you're going to automatically make antibodies to it. You have to get exposed to it somehow. And that's the whole point of a vaccine, is to be able to do it kind of asymptomatically and prepare your body in case you get really exposed and that virus gets in your body. Well, the response here to this Rh antigen, is the same way. So if you're Rh negative, it means you don't have the antigen on your cell surface. Therefore, if you come across or get exposed to Rh positive blood, a red blood cell that does have the antigen on the cell surface, you see it as being a foreign entity and you will start making antibodies to it. Now, if you're Rh positive, you're never going to normally make those antibodies, because why? You don't make antibodies normally to the antigens on your cell surface. So if you're Rh positive, you don't normally have to worry about ever making any Rh antibodies. About 85% of Americans are Rh positive, so it's way more common to be Rh positive than Rh negative, and it's dominant over being Rh negative. So what's the issue? Well, the problem is when a mom is Rh negative in her blood type and she's carrying a fetus that is Rh positive. Now, usually the first pregnancy, is not the issue. The blood between a fetus and the mother are separated, from one another, and they normally will not, intermingle under most normal circumstances. However, there are occasions when that can happen, like through amniocentesis or trauma. There are different things that can happen. And for most women who are Rh negative, they don't, that's why it's important to know what your blood type is that if you are pregnant and you find that you're pregnant, then you should be advised to immediately have a blood draw done and to confirm that mom does not have any Rh antibodies. And you can do that through, what's called a titer. You can take a specimen of blood and you can try to look and perform tests to determine if she has any Rh antibodies. Because if she does have these antibodies, they can actually cross the placenta, and then it can attack the fetal blood and actually lead to death. So it depends on when you start to amass these antibodies, but there's, less severe and more severe times, or responses. The first pregnancy, as long as there's no intermingling of blood, then she should be not producing any of these antibodies. But upon vaginal birth or during, the birth process, blood can be mixed between the two, and she becomes what's called sensitized, and she starts making those antibodies. So to keep from ever producing them at all, you can go through a series of injections of RhoGAM, and that's a serum that contains anti-Rh antibodies, and it prevents mom from developing the Rh antibody. So it essentially will bind to any loose red blood cells from the fetus, that maybe is getting into mom's circulation. And those antibodies will quickly bind to it so that her body doesn't recognize it. That response of, that's the response, but once, if mom does have these antibodies and it gets across the placenta, then that condition in the fetus is called erythroblastosis fetalis, or hemolytic disease of the newborn. If it occurs, you don't get any mingling of blood till, like the last trimester or last two months of development. And now she starts to make these antibodies, then there's not as much damage that can be done. Then you've made these antibodies before you even got pregnant. And now in early stages of the pregnancy, these antibodies are crossing the placenta, then you're not going to have a very favorable outcome whatsoever. There are things you can do once that process happens. Once you start making the antibodies, you're no longer a candidate for taking RhoGAM. You have to be not have any anti-Rh antibodies in mom's circulation. So as long as she's never been sensitized, then she can go on RhoGAM. If she's already sensitized, then there are different umbilical transfusions and some things like that that can be done. All right, this is when you put this PowerPoint in slideshow mode like this, if you download it, there's a WBC identification game that you can go and play with. I think they're kind of fun. I believe it's purposegames.com. That's where I got that. I'm not going to go into it now. You can do that on your own because it requires me to stop the share because it goes from the PowerPoints here to another website. So I don't want to break the share at this point because we're just about done. And then here's another game as well. Or you could just go to purposegames.com and put in white blood cell, differential game, a couple different. They have a lot of different games. There's actually some really good ones. All right. And then these are just what I call FYI notes, for those people who want to know. I talk in more detail here about jaundice and the pathway of that conjugated bilirubin. Once it's in the small intestine, it gets converted to what's called urobilinogen. And I was describing how some of that is going to get reabsorbed in the small intestine. So it just says part 1, urobilinogen is absorbed in the portal blood about 20%. And out of the 20%, most of that urobilinogen is going to be returned right back to the liver, like 90% of that 20. It's got to go right back to the liver and go right back down the bile tree again and go into the small intestine. But a small amount of urobilinogen reaches the peripheral circulation and goes to the kidneys, about 10%, and is excreted in urine, thus giving it the yellow tinge. Part of the urobilinogen is oxidized into stercobilin and excreted in feces. That's about 80%. So most of what you're getting rid of is going to be in the form of stercobilin. Jaundice, that's like I said, the yellowing of the skin. When it comes to diagnosing jaundice, it falls into one of 3 categories. It's either considered as prehepatic, hepatic, and posthepatic. So we call it prehepatic or hemolytic. I think of it still as prehepatic. So the first stage, as we said, to breaking down red blood cells occurs in the spleen. So if the etiology of all these red blood cells and all this conjugated and unconjugated bilirubin, is coming from something happening at the spleen, which is prior to it getting to the liver, which is hepatic, then we just call it prehepatic. So the pathology is occurring, prior to arriving in the liver. And generally, if it's prehepatic, it's going to be because a massive number of red blood cells is dying off and overloading the spleen, and the spleen is producing this massive amount of unconjugated bilirubin that is now traveling to the liver, and the liver is going to have to process. So it's starting with some issue prior to these molecules ever getting to the liver. When it's considered hepatic, the pathology is located within the liver itself. It could be, extraordinary. It could be liver cancer. It could be extraordinary hepatitis, where you have bad inflammation, and viruses, in the liver. Or everything else prior to that is fine. It's something past the liver. So something along that biliary tube to the gallbladder, down through the pancreas into the small intestine, and they're out. The pathology is located after the bilirubin is in the conjugated form by the liver, and that it's something beyond that point: the gallbladder, the pancreas, small intestine. And then this just helps you with a differential diagnosis of the different conditions. So if you're normal, if you have a prehepatic, hepatic, or post-hepatic obstruction, or etiology, then see on the top, we have serum bilirubin, of which we have conjugated and unconjugated. And then you have urine, you either have urobilinogen or bilirubin, and then you have fecal urobilinogen, and along on the horizontal, there are the normal values. What would it be in serum, for conjugated and unconjugated? What would be the urobilinogen? There's a big X in bilirubin because it's not normal to have bilirubin at all, in urine. And then how much should be in feces? 40 to 280 milligrams in a 24-hour period. Right? And then it takes hemolytic. So when you have a smiley face, it just means it's normal. And then the up arrows mean it's elevated, elevated. Again, should still not be found in urine, the red X, and in feces, it will be elevated. If it's a hepatic etiology, then everything, the conjugated and unconjugated forms in serum are both going to be elevated, and the urobilinogen in urine will be decreased, and they will be present now in urine as bilirubin, and so forth. So you can read across there, and there's a video that goes with it. This is the video that goes with it. Now, that video is going to walk you through this. There's not much talking going on, but it's just you can just go ahead and watch it yourself. There's not a lot of talking. About halfway is where I would stop, because it gets into a lot of further detail as how you would use this. I believe I found this video from someone that prepared a video for the USMLEs, and I was like, oh, this is actually pretty good. At least the visual part of it. It shows some poop and things like that, but otherwise just disregard it. But for people who maybe are going to go to PA school, I think this can be rather helpful. So it lets you see what you would expect to find elevated or depressed, either in the blood, conjugated and unconjugated forms, and what you would expect to find in urine. Okay, and that is the end of the blood chapter.